Hello everyone, this presentation will be on anatomy and the applied physiology of the cardiovascular system. Now, if you would have seen in my channel, most of the videos are pediatric related, and if you see the topic at face value, you might be thinking, why is it important to revisit the anatomy and the applied physiology? The cardiovascular system is undoubtedly one of the most challenging systems for a medical student to understand, both clinically as well as theoretically as well. And the foundation of understanding the cardiovascular diseases, be it the congenital spectrum or the infective spectrum, lies in the anatomy and the applied physiology. Now, with that brief introduction, I'll introduce the scheme on which I'll be talking in this presentation. Firstly, the structural anatomy of the heart, followed by the electrophysiology, brief revision about the cardiac cycle, about cardiac output and cardiac reserve, the physiology and the basis of the heart sounds, including a few basic murmurs, as well as about fetal circulation and transitional changes that occur at birth. Now, the structural anatomy of the heart is not a new topic. It is something which everyone in the medical fraternity is well versed with. To just broadly revise, we know that the heart comprises of 4 chambers, which are divided based upon 2 septum, the interatrial septum, interventricular septum, and the atrioventricular septum. Now, we know that the heart comprises of 4 chambers which have 2 atria, the left atrium and the right atrium, and 2 ventricles, the left ventricle and the right ventricle. Now, structurally we know that out of the left ventricle the aorta gives rise, and from the aorta it goes upwards, outward, and gives out the various branches, and from the right atrium it gives out the pulmonary trunk, which divides into pulmonary arteries. From the lungs, the circulation returns through the pulmonary vein, and through the pulmonary vein enters back into the left atrium, and based from the inferior vena cava and the superior vena cava, blood enters into the right atrium. The peculiarity of the circulation of the heart is generally arteries carry oxygenated blood and veins carry deoxygenated blood. But the pulmonary artery contains deoxygenated blood, pulmonary vein contains oxygenated blood. This is the only exception with regard to the artery and the venous circulation. Now, as we know that there is a separation, blood does continue to flow freely. The mitral valve separates the left atrium from the left ventricle. It has 2 leaflets and hence it is called as a bicuspid valve. So, mitral valve is also called as a bicuspid valve. It comprises of 2 leaflets, what you can see in this diagram. I'll just zoom in. So, you can see the 2 leaflets. As the name suggests, the aortic valve separates the left ventricle from the aorta. So, this is the aortic valve. If you come to the right side, the tricuspid valve separates the right atrium from the right ventricle, and as the name suggests, it comprises of 3 leaflets. And the pulmonary valve separates the right ventricle from the pulmonary artery. So that is a broad revision of the structural anatomy of the heart. Moving forward, if we do consider histologically, cardiac muscle is unique as compared to other skeletal and smooth muscles. Certain unique properties of cardiac muscle fiber include automaticity, which means that the beat to contain sustained contractions is automatically generated within the cardiac muscle itself. Rhythmicity is maintained. When I say that rhythmicity is maintained, I mean that the rhythm of contraction and relaxation continues on its own. Conductivity occurs within the cardiac muscle, and when I say conductivity, the impulse transmits from one portion of the muscle, from one cell to the other. It is a conductive response and it functions as a syncytium. While mentioning that, I will mention about functional syncytium. If we do assume that we have multiple cardiac muscles present, the entire unit functions as one syncytium as a whole, and it does not function as individual units. The cardiac muscle, in addition to this, is highly excitable compared to other muscles and contains a long refractory period as well. So these are some unique properties of the cardiac muscle which is not seen in either skeletal or smooth muscles. Now, coming to the cardiac electrophysiology, like I mentioned, electrical impulses are generated by the cardiac muscle, and these get transmitted, which result in transduction by the cardiac muscles to undergo contraction. Now, transduction is nothing but conversion of one form of energy into another form. So what is happening is these electrical impulses are getting converted into mechanical impulses, which result in this contraction. And any electrical impulse requires a source and a basis for this to occur, and this basis occurs at the SA node. Now, I'll come to the SA node a little bit in detail, but before that we'll understand the cardiac action potential. Now, diagrammatically what you see is a contraction chart and the electrophysiology chart of the cardiac muscle. What you see 0 in this phase here is due to the rapid depolarization due to the opening of the sodium channels. So, as you can see, sodium comes in during this depolarization phase. Once it reaches its peak, the phase what you see as 1 is due to the rapid repolarization due to closure of the sodium channels. This small mini segment what you see here, that is 1. That is a rapid repolarization due to closure of sodium channels. What you see, the stagnant part, which is marked as 2, is the plateau phase. The plateau phase is because of the opening of the calcium channels, and it's during that time where calcium moves in and potassium moves out. What you see as 3 is the final repolarization phase because of the stoppage of the calcium channel. So this portion what you see marked as 3 is a final repolarization which results in a stoppage of calcium. During this time what potassium had come inside comes outside. And the stage what you see as 4 is restoring of the resting membrane potential. Now, restoring the resting membrane potential is ensuring that the system is brought back to normal such that the next cycle can begin. This is a continuous process. This is an automatic process. It is a rhythmic process. This impulse is conducted and it results in the contractility. So, based on this one action potential, we have understood the unique property of the cardiac muscle. Now, subsequently, what we see is also called a pacemaker potential. A pacemaker is what discharges the rhythm and ensures that automaticity is maintained, and the resting membrane potential is also called as the pre-potential. Now, if we understand in this chart, the elements of 1 and 2 is taken out. So, by the same numbering, we understand that there is a rapid depolarization due to opening of the sodium channels in the SA node, and a sudden repolarization due to the stoppage of calcium influx. The remaining happens side by side, and hence the resting membrane potential is suddenly restored immediately. This chart, what you see diagrammatically occurring, is what ensures that the pacemaker potential is generated and that the rhythm is generated at the cardiac SA node. Now, till now I was talking about the SA node. The SA node is where the origin of the electrical impulses occur. And schematically, if you do see, from the SA node it comes to the internodal pathway. The SA node is a primary pacemaker which is situated upon the right atrium, which contains pacemaker cells. The velocity of the impulse here is 0.05 meter per second. So it is quite fast, and considering the size of the myocardium, it ensures that the electrical impulse is transmitted almost instantly. Now, from the SA node, it comes to the internodal pathway. The internodal pathway are 3 in number. So if I do draw it diagrammatically, I have an SA node and I have an AV node. There are 3 internodal pathways which are present: anterior, middle and posterior. The anterior tract is the tract of Bachmann, the middle tract is the tract of Wenckebach, and the posterior tract is the tract of Thorel. Now, this ensures fast conduction between the SA node and the AV node. Now, the AV node is also containing certain cells which is similar to the SA node, but it is situated at the lower part of the atrium and comparatively has smaller fibers and slower conduction. What we call AV nodal delay is 0.1 second. So this is ensured because the impulse needs to be transmitted across, and that 0.1 second can be considered as the time required for the transmission. From the AV node through the bundle of His, it moves up to the Purkinje fibers. The bundle of His signifies the beginning of the Purkinje system, and here it further subdivides into 2: right bundle branch which innervates the right ventricle, and left bundle branch which innervates the left ventricle. Now, clinically we have heard many terminologies such as bundle branch block. A blockage in transmission through this bundle of His will result in the bundle branch block, which gives the arrhythmias which manifest clinically. Subsequently, there is also the Purkinje fibers. The Purkinje fibers are subendocardial bundles which result in the fastest conduction. Now, moving on to a property called Frankstarling Law. The Frankstarling Law states that the force of the contraction of the cardiac muscle is directly proportional to the length of the muscle fiber. So, effectively, what we are saying is if the muscle is, say, this small, the force of contraction, if we do quantify it, I'll use two colors to highlight this property. This is muscle A and this is muscle B. So what you see in red signifies the muscle bulk, and what I'm going to draw in blue signifies the contraction force. So assuming that muscle A is smaller in length, so this what I've drawn in blue is FA, that is the force of contraction of muscle A. And assuming that muscle B is double the size of A, though it shows more, even if I do say triple, FB is substantially higher because the size of muscle B is much higher than size A. That is what we call as the Frankstarling law, which is applied in cardiac muscle. Now, coming to the cardiac cycle is a description of the sequence of events which is happening in the heart beat to beat. Now, we further subclassify this into two, namely the atrial events and the ventricular events. And within the atrial events, we subclassify it into atrial systole and atrial diastole, and ventricular events also into ventricular systole and diastole. To remember in general sense these new terminologies of systole and diastole, systole is a contraction phase and diastole is a relaxation phase. So this is a contraction phase and this is a relaxation phase. Now diagrammatically, if we draw this circle and assume it to be like a clock, the cardiac cycle lasts for 0.8 seconds. And in general, if we do see, we can understand this in terms of atrial events and ventricular events. So if we assume this to be 0, that is the top of the clock. If we consider atrial events, atrial systole lasts for 0.1 second and atrial diastole lasts for the remaining 0.7 seconds. So we have completed one cycle of 0.8 seconds and the next cycle of atrial systole begins. Then again atrial diastole will happen and so on and so forth. But if we consider ventricular events, there is a slight incoordination between the two. Ventricular systole will begin when atrial diastole begins. So both do not occur simultaneously. So ventricular systole will happen for 0.3 seconds and the remaining 0.5 seconds will be ventricular diastole. The duration of the cardiac cycle remains the same. It remains as 0.8 seconds for even ventricular events and atrial events also. But atrial events is divided as 0.1 and 0.7. Ventricular events is divided as 0.3 and 0.5. Moving on, if you consider the ventricular systole, like I mentioned, ventricular systole is a phase of ventricular contraction. In this phase of ventricular systole itself, we have three subphases. The first is isovolumetric contraction. The name itself suggests isovolumetric, implying that volume remains constant. Now in this phase, the first heart sound appears. There is a rise in the ventricular pressure and there is a closure of the AV valve also. Now we have a ventricle. We will assume that this is the left ventricle separated by the bicuspid valve and the aortic valve. Now the first heart sound appears because of the closure of the AV valves and there is a rise in the ventricular pressure because there is a contraction. The contraction occurs because of this myocardium and the ventricular pressure rises because the volume reduces. We can consider roughly that because the volume is constant and the pressure rises, the pressure also builds accordingly. Now, second phase is rapid ejection phase, where if we consider the same left ventricle where the aortic valve was closed till now and suddenly open. When the aortic valve opens, the blood will suddenly gush out because of the pressure gradient. This was a high pressure gradient and this was a low pressure gradient. So by the law of physics, blood will go from the high pressure gradient to the low pressure gradient and there will be a further increase in the ventricular pressure. During this ejection phase, the contraction still occurs. And as a result of that, the pressure is continuously building higher. So the high pressure keeps on building higher and higher and the blood gushes out as fast as possible. The third phase is the reduced ejection phase. Now it is here where up to a point only blood can be pushed out of the ventricle. And once the aortic valve is kept open and once bulk of the blood goes out, the aortic blood flow is markedly decreased because whatever blood had to come out has already come out, and there is subsequently a slight drop in the ventricular pressure, at which time the aortic pressure is more than the ventricular pressure. So in this gradient, if you see, the pressure here will be much more than the pressure here. Now, after the systole is complete, the ventricle moves into the diastolic phase. Diastolic phase, like I said, is the phase of ventricular relaxation. In this phase, there are 5 subphases. The first is the protodiastolic, followed by isovolumetric relaxation, first rapid filling, slow rapid filling, and the last rapid filling state. In the protodiastolic phase, there is a slight further flow of blood because of the pressure gradient and because of the inertia, but there is no substantial change as far as the pressure is concerned. There is no active contraction. Whatever flow happens because of inertia happens. Now, in isovolumetric relaxation, there is a fall in the ventricular pressure, but there is no change in the volume. The name itself suggests isovolumetric, volume constant, and relaxation. The first rapid filling phase is where there is an increase in the ventricular volume, and this is because of a gush in blood. So imagine that this is the left atrium and this is the left ventricle. When this valve opens and blood is full here, blood will move from atria to ventricle. So this is the first rapid filling phase based on the pressure gradient. Now the second filling phase is a slow rapid filling phase. In the slow rapid filling phase, there is a slow rise in the ventricular volume, but there is no change in the pressure. This happens because initially there was a high amount of pressure which was here, and that has compensated to a point in between where the amount of blood in left atrium and left ventricle both are equal. So once it has reached a point of equalcy, there is no pressure gradient, so it is only based on a slight amount of gravity that blood will continue to grow. But eventually what will happen is the last rapid filling phase, where there is a continuation of the flow but the rate is reduced. Effectively, the key point what you would have noticed I'm highlighting is there is always a flow of blood from a high pressure gradient to a low pressure gradient. This is a fundamental physical concept which we must understand, and blood always flows in the direction of high pressure to low pressure. Now subsequently, cardiac output is defined as the amount of blood ejected by each ventricle. Now this is expressed in terms of stroke volume per heart rate, and this is the amount of blood ejected by each ventricle per minute. It is not in per cycle, it is per minute. Cardiac output is stroke volume, that is the amount of blood ejected by each ventricle per cycle into heart rate. And the stroke volume is 22.2 into h to the power of 0.3 in males and 20.85 into h into 0.36 for females. This regression equation looks complicated, but it is more of a research perspective, and I've included it because it's a common question asked in the entrance exams. Now, cardiac reserve is another concept, which is the amount of blood that can be pumped by each ventricle in addition to the cardiac output. Now, till now what we were talking is at a physiological level. Now, clinically if we do come, there are auscultatory areas to auscultate for the heart. Now, generally we do know that there are 5 areas. The first is the aortic area, where you can auscultate for the aortic valve. This is present at the right second intercostal space, as you can see marked here. You can identify the second intercostal space because of the sternal prominence. The right second intercostal space is where you can hear the aortic valve. Pulmonic valve is present at the left second intercostal space, where you can auscultate for the pulmonary valve. Erb's point is present at the left third intercostal space, which is one space below the pulmonic area. If you auscultate for the tricuspid area, it is present at the left lower sternal border in the fourth intercostal space, and mitral valve in the left fifth intercostal space just medial to the mid-clavicular line. So these 5 auscultatory areas are important because they should be auscultated in order to pick up the heart sounds, which we will discuss in detail now. And it is important to note that while auscultating, you must go in a Z-track fashion to ensure that nothing is missed. So you start with the mitral area, move to tricuspid, move to pulmonic area, and then move to aortic. So by doing this in a Z-shaped manner, as you can see, I'll redraw it over the areas to make it better understood. By going in the Z-track pattern, you ensure that nothing is missed out. And hence this is also called as a Z-track pattern of auscultation. Now, coming on to the heart sounds, we know that there are 4 heart sounds, namely S1, S2, S3 and S4, and they are all produced by the closure of heart valves. This is a very key concept to understand that heart sounds are produced by the closure of heart valves. The first heart sound is produced because of the closure of the AV valves. And as we know, the AV valves are nothing but the mitral valve and the tricuspid valve. The first heart sound occurs at the beginning of systole and is characteristically heard as a lub sound. And the frequency of it is 25 to 45 Hz. Now, compared to normal, we do get a loud S1 where the high cardiac output is seen, such as fever or anemia. And a soft S1 is seen where there is a low cardiac output or a poor left ventricular function. Second heart sound is characteristically seen because of the closure of semilunar valves. The semilunar valves are the aortic and the pulmonary. So these are the semilunar valves. And the second heart sound marks the end of systole and it is characteristically heard as a dup. Generally, S1 is louder than S2. So the closure of the AV valves is louder than the closure of the semilunar valves. And the exception of this is S2 louder than S1 is suggestive of pulmonary hypertension. Now, in S2, one interesting phenomenon what we understand is the split. The split is sometimes physiological and it is best heard at the upper left sternal border in the pulmonic area. This is because the pulmonary valve closes later than the aortic valve because the aortic valve is helped to be closed early by the increase in the pressure. The second heart sound, like I mentioned, has a split between A2 and P2. A for aortic, P for pulmonary. So once that concept is clear, if there is an increased separation between this A2 and P2 in inspiration, it is normal. If there is a decreased separation between A2 and P2 in expiration, that also is normal because this is a physiological variation of the A2 and P2. But a wide split is seen in atrial septal defects as a result of overfilling of right ventricle and delayed closure of the pulmonary valve. Mild pulmonary stenosis and right bundle branch block also do cause a wide split. We'll understand the concept of split when I show diagrammatically in later slides. Subsequently, a fixed split is seen in a smaller atrial septal defect and a single S2 is heard in pulmonary artery hypertension, transposition of great vessels and structural valvular abnormalities. But a paradoxical split occurs where the aortic valve closes last in left bundle branch block or in severe aortic stenosis. Now, moving forward, the third heart sound is also called the Tennessee heart sound. It's called Tennessee because it's heard like that as a gallop. It is also known as a ventricular gallop rhythm. So, a large amount of blood striking the compliant left ventricle can cause a third heart sound and is sometimes heard in normal children also. It is better heard with the bell of the stethoscope over the apex or the lower left sternal border. The fourth heart sound is also called as Kentucky. Please excuse the mistake in the slide, it is S4. It is called the Kentucky heart sound and is always pathological. It is caused by the vibration of the ventricular valve during atrial contraction, and if it is heard just before S1 and it indicates a reduced ventricular compliance. Now, moving on, till now what we saw S1, S2, S3, S4 are the heart sounds in which we consider S1 and S2 as generally normal heart sounds. S3, S4 are also physiological heart sounds but they are abnormal. Murmurs are abnormal heart sounds and a palpable murmur is called a thrill. This is a very important concept what we need to keep in mind while identifying a mistake in the auscultatory findings of the cardiovascular system. Now, if we want to assess a murmur in detail, we have to identify the murmur with regard to the relation in the cardiac cycle. So, we need to identify whether it is a systolic murmur or it is a diastolic murmur. Subsequently, we need to identify the site of maximal intensity and identify the character of the murmur and see whether it is enhanced by any maneuvers. Subsequently, we need to see whether the murmur has any radiation and whether it is possible to grade the murmur also. So with that, we move on to the timing of murmurs. In simple terms, a systolic murmur occurs between S1 and S2. So S1 is the start of systole, S2 is the end of systole. So any murmur between S1 and S2 is systolic murmur. If you consider a diastolic murmur, it is between S2 and S1. So I'll draw it here in a more simple manner to understand. S1 to S2 is a systolic phase, so any murmur here is a systolic murmur. S2 to S1 is a diastolic phase, so any murmur here is a diastolic murmur. Subsequently, S1 to S2 is again systolic, S2 to S1 is again diastolic, and the cycle repeats itself. A continuous murmur is where you cannot appreciate any differentiation between the two. So, if we come to systolic murmurs directly, the first type of murmur which I'll be describing is an ejection systolic murmur, which could be innocent or it could be pathological also. It is characteristically described as a crescendo-decrescendo murmur because the intensity of it first will gradually increase and then decrease. This is seen in aortic stenosis or in pulmonary stenosis. So if you see in this diagram here, S1 is shown along with the split of A2 and P2. The murmur is seen only in the systolic phase, so it's a systolic murmur. It is a crescendo, meaning the intensity is increasing, and decrescendo because the intensity is also decreasing. The second type what you see is a pansystolic murmur. By pan, I mean throughout, and systolic implying systole. So a pansystolic murmur is seen throughout the systolic period. This is seen in a ventricular septal defect, also seen in mitral regurgitation and tricuspid regurgitation also. So similarly, if you see the diagram, there is S1, the split between S2 of A2 and P2, and again S1. So this is the systolic phase and this is the diastolic phase. The murmur is present throughout the systolic phase. You can see that and appreciate the difference between the first ejection systolic murmur and what we saw. In this, the first portion of systole is normal. If you do see here, the first portion of systole is normal, whereas here throughout the systolic phase there is a murmur. Hence it is called as a pansystolic murmur. Subsequently, you also have what is called as a systolic click. A systolic click is a late systolic murmur. It is seen in mitral valve prolapse. Now, between S1 and S2, if you hear an abnormal sound followed by a crescendo-decrescendo murmur, it is seen in mitral valve prolapse, which is a systolic click. You can identify the difference between between a pansystolic murmur and a systolic click because in pansystolic murmur, the murmur was there throughout. Here initially it's normal and you hear an extra abnormal heart sound which you can easily confuse to be S2. Now you also have ejection clicks which occur early in diastole, which is seen in aortic valve diseases also, which is similar. So here you had a mid-systolic click, here you had an ejection click. The difference what you can see, here after S1 there was a gap of normalcy followed by a click, whereas in an ejection click it happened along with S1 in conjunction. Moving on now to diastolic murmurs, you have early diastolic murmurs which are seen in aortic regurgitation. Characteristically, this is best heard in left lateral position on expiration and slightly sitting forward. And between S2 and S1 after the split, there is a reduce in the intensity followed by absence of the murmur slightly. A mid-diastolic murmur is characteristically seen in mitral stenosis, where between S2 and S1, it was a slight phase of normal, and in mid-diastole, the murmur was heard. Subsequently, you also have opening snap, which is characteristically seen in mitral stenosis as well. So, if you consider the systolic time, before hearing the mid-diastolic murmur, you heard that additional click sound, which is like a snap. That is called as the opening snap, which is also called as a diastolic rumble. It is called rumble because if you do hear it, it does hear like a rumbling sound. Now, moving on to continuous murmurs, it is seen in patent ductus arteriosus, atrial septal defects, in certain AV malformations, in aneurysms and peripheral pulmonary stenosis as well. Now, what we heard till now was a murmur occurring in either systole or diastole. But in PDA, if you do see here, the murmur persists throughout systole, throughout diastole also. It is a totally continuous murmur and it is not possible to distinguish it either as systolic or diastolic, and hence the name continuous murmur. This is another diagrammatic representation of that between S1 and S2. It is a continuous murmur seen in ASD. And if you do compare it to the continuous murmur seen in pulmonary stenosis, the intensity does vary. Pulmonary stenosis continuous murmur will show a crescendo-decrescendo pattern, which is why I have highlighted the slide. Whereas in ASD, it more or less remains constant in intensity. Now, coming to that point of intensity, the upper left sternal edge is characteristically where the intensity of the pulmonary valve is heard best, and hence pulmonary murmurs are best heard there. The upper right sternal edge is reserved for aortic. The lower left sternal edge is reserved more or less for the tricuspid, and the apex is more or less reserved for the mitral area. This is the site of maximum intensity of a murmur. Now, if you see the individual murmurs which are heard there, at the pulmonary area, you hear characteristically the murmurs of pulmonary stenosis, flow murmurs, arterial stenosis, PDA, and tetralogy of Fallot also. At the upper right sternal edge in the aortic area, you hear aortic valve stenosis, subaortic stenosis, and supravalvular aortic stenosis. The lower left sternal edge is where you hear aortic regurgitation, but it is best heard over the third and fourth intercostal space only, followed by VSD, atrioventricular septal defects, and certain innocent murmurs also, apart from cardiomyopathies and tricuspid regurgitation. At the apex, it is best heard for mitral regurgitation, mitral stenosis, and mitral valve prolapse. Now, like I mentioned, certain murmurs are enhanced by certain maneuvers. In left lateral position, S3 and mitral murmurs are best heard. On slightly bending forward, aortic murmurs are heard well. On slight change with expiration, left-sided murmurs are heard. And Valsalva maneuver helps in hearing the murmur of hypertrophic osteocardiomyopathy. Now coming to radiation, aortic murmurs do tend to radiate to the neck, and pulmonary murmurs radiate to the back and to the side. Pulmonary valve murmurs radiate to the axilla also, and coarctation of aorta murmurs do radiate to the interscapular region also. But the point which I want to highlight is innocent murmurs are non-radiating. There are certain criteria to call a murmur as innocent, which namely include soft, systolic less than grade 2, non-radiating, and not enhanced on lying down or variable. So these are certain criteria to call a murmur as innocent. Now coming to a grading of the murmurs, I am grading the systolic murmurs here in this slide. The diastolic grading is only 1 to 4. I am not going to touch upon that because generally diastolic murmurs are always pathological. A systolic murmur of grade 1 is barely audible. A systolic murmur of grade 2 is of medium intensity. A systolic murmur of grade 3 is loud but does not have thrill. A systolic murmur of grade 4 is present, loud with a thrill. Grade 5 is loud but requires a stethoscope to be heard. And a grade 6 systolic murmur is audible without a stethoscope also. Now moving on to the last topic of this presentation, it's fetal circulation. Now there are certain transitional changes which do occur at birth. The transitional changes I will highlight afterwards. But first we will just see the fetal circulation, what does happen. We know that the placenta is where the bulk of the nutrition occurs for the baby. From the placenta through the umbilical vein, the circulation bifurcates into the liver and ductus venosus. From ductus venosus, it moves to the inferior vena cava, as is the case from the liver also, fetal liver. The fetal liver is a source of erythropoiesis. So the fetal liver is an important organ which requires blood flow. Subsequently, through the right atrium to the right ventricle into the pulmonary trunk, and from the pulmonary trunk into the lungs to the pulmonary veins to the left atrium. But from the right atrium, the blood also goes through foramen ovale to the left atrium, and from pulmonary trunk through ductus arteriosus also reaches the aorta. Now ductus arteriosus is physiologically present in the fetus but gets closed at birth. So there is a bifurcation in the flow of blood, and from the aorta to systemic circulation through the umbilical arteries back to the placenta. Now schematically we have understood how this works. I'll just repeat it once more as an overview. Placenta to umbilical vein through ductus venosus to the inferior vena cava to the right atrium. From right atrium, some amount through foramen ovale to left atrium, some blood through the right ventricle to the pulmonary trunk to the lungs to the pulmonary vein to the left atrium. From pulmonary trunk, some blood directly came through ductus arteriosus to the aorta, and some came from left atrium to the aorta. And from the aorta to systemic circulation to umbilical arteries back to the placenta. Now, having understood this schematically, we can see the same occurring here. So, we'll trace the path once from placenta through the umbilical vein to the inferior vena cava to the liver. From the inferior vena cava, it comes into the circulation. From the circulation, it has reached the left atrium. From the left atrium, to the right atrium, to the right atrium, to the right ventricle, to the lungs. Some amount has already crossed over through foramen ovale. From the lungs, it comes through the pulmonary arteries to the left atrium. From the left atrium to the left ventricle to circulation, and circulation it has come backwards. Now, one key point what you would have understood here is ductus arteriosus does remain patent, and based on our schematic we understood that ductus arteriosus is a connection between the pulmonary trunk and the aorta. Pulmonary trunk contains deoxygenated blood to an extent, and aorta is supposed to contain oxygenated blood. So, ductus arteriosus acts as a shunt. A shunt is a mechanism of transfer between a deoxygenated area and an oxygenated area. So, with that we come to the transitional changes which occur at birth. These transitional changes include a fall in the pulmonary vascular resistance, which occurs rapidly at the first cry at birth but can continue up to 3 months also. There is also a fall in the pulmonary arterial pressure and a loss of placenta from circulation because it is clamped and cut from the cord. There is also a physiological closure of ductus venosus and ductus arteriosus along with the closure of foramen ovale. And these transitional changes which occur at birth are very important to understand. On that note, I thank you all for patiently listening up to the end of this presentation. The aim of this was to revise the basics of anatomy and applied physiology before going in to understand the cardiovascular system diseases in detail. Now, generally what we do classify cardiovascular system diseases in pediatrics include congenital spectrum. The congenital heart diseases is what we do commonly encounter, which requires a deep understanding of the cardiac physiology. Apart from this, you also have structural disorders and you also have infectious disorders. But irrespective of what spectrum of CVS disorders you do consider, the basic understanding what we had in these slides is important. I've done my best to try to simplify it, and I've not gone too much into detail about anything, but I have only focused upon what is relevant to understand the clinical anatomy and the applied aspects which is required for a deep understanding. Thank you all for listening once again, and I hope you tune into the next video also.